Holly, we're going to be
We are going to
awesome,
be talking about the birds and the bees and answering all of your questions. We had a really great webinar a couple weeks ago called Sex Ed for Adults, and we had so many wonderful questions. We are going to continue answering some of those questions. We want to answer your questions, so please feel free to add them in the comment box. So questions for Dr. Rodgers and Dr. Go. Did I miss anything? Is there anything you want to add?
No, I think that certainly those of you who are listening are welcome to add your questions in. We're going to do some of the questions that we didn't have time to do on our webinar that we thought were good to continue the conversation of sex ed for adults. And then if you guys have questions, feel free to comment and add them. And Holly, hopefully we'll be able to go through those and answer questions and all that kind of stuff. So, all right, Holly, you want to get us started?
Sure. So Dr. Rodgers, I thought this was a really good question that we got during the webinar about egg freezing. So if I have frozen eggs with FCI and you're 35 or older, is it better to try on your own, or should you use the frozen eggs that you have?
I love this question because I think it really depends on how much older than 35 are you, right? Are you 35, 36, or are you 43, 44, right? And I think that this is a great opportunity if you're ready to have a family, to meet back with your fertility doctor. Maybe you froze eggs, relatively recent or a long time ago, who knows. It's a great time to meet back with a fertility doctor, check what your current fertility status is, talk about the chances of success with the eggs you have frozen, because it's never 100%, and what your family goals are. So if you want 3 kids and your chance of success of having those 3 kids with the eggs you have is relatively low, probably benefits you to try on your own, understanding that maybe or with help, depending on where your fertility stuff, testing comes back with. Sometimes we'll save those frozen eggs for baby number 2 or 3, something like that. I don't know, Dr. Go, if you have any other thoughts on that.
Yeah, I think I agree. I think if you've never tried to conceive naturally, but you have, eggs frozen, I think it's always worth to try, maybe initially. And then sometimes those eggs are, hopefully used for baby number 2 or 3. But again, definitely depends, I think, at what age you're hoping to try. So again, like Dr. Rodgers said, but if you've frozen eggs with us, a great kind of point to jump back into treatment and just figure out what your options are.
Yeah. Or even just testing, see where your AMH is, those kind of things.
Yes.
Thank you. We have a couple of questions coming in on Instagram regarding age and fertility. What is recommended for 41 or older? Should you just go into donor eggs, or try traditional IVF with your eggs?
Yeah, I think that's also a really great and fair question. I think the option of donor eggs is always going to give you the probably highest chance of success. But again, if you've never tried with your own eggs, and at 41, I think it's worth testing and seeing where your ovarian reserve is before you jump right into using donor eggs. Knowing that, again, that's probably the most successful, but I think it's always worth to try. If the goal of yours is to have a genetic child, I think most of us wouldn't push you into using donor egg as your very first option. I think really reasonable to kind of assess your own status before you utilize that resource.
I see one of our fertility nurses on here. So thanks for joining. I see. That's amazing. I love that support.
Thank you. See. Another question, IVF versus natural process. Which one is better to have a healthy baby?
Sure, I can take this one. So, I think that it's an interesting question, right? Obviously, most people want to, conceive and have their children naturally. It really depends on your age and what other risk factors you have. So if you're 40, your chance, if you get pregnant on your own, there's about a 40% risk of miscarriage and a 1% risk of Down syndrome. And so if you're 40, you still have a very good chance of being successful and having a baby, but there's a very high risk of miscarriage, and you're starting to see that increased risk of Down syndrome. So, people at that stage, which is still younger than me, so I count it young, but might benefit from, for example, IVF with genetic testing. I think that, you shouldn't just do IVF just to do IVF, but I think that if you're 30 or even 35, your risks of, for example, miscarriage, Down syndrome are much lower. And I really think it's a very individualized decision. But just because a baby comes from IVF doesn't mean it's unhealthy. Sometimes actually IVF babies are healthier.
Great, thank you. So speaking of kind of egg quality and egg quantity and quality, which has to do with age, we had this question from the webinar. I've had my follicles checked. I don't know what it means to have a good count. Can you explain that? Dr. Go, do you want to explain that?
Yeah, of course. So your egg count or an antral follicle count is kind of a resting cohort of eggs that you have on your ovaries that we can count on ultrasound at any given time. So it's not all the eggs you have in your ovaries, period, but it's kind of a snapshot of what we can see with that cycle. And so there's kind of a wide range of what normal is, but I would say anywhere from like 12 to 30s is probably in the normal range. When you get under 12, so less than like 6 eggs on each side, you start getting concerned a little bit about what we call diminished ovarian reserve. And then once we get 40 or plus antral follicles in total, so maybe over 20 on each side, we start thinking, is there something else going on, potentially like a PCOS picture, where you have so many follicles, but you're not ovulating regularly. So there's definitely a wide range that's considered normal and a good number, and it kind of is related to also your age and what your other hormone tests show. But doing an antral follicle count with your ultrasound is a great starting point, but definitely just kind of one piece of the puzzle.
Thank you. And Dr. Rodgers, do you know of any ways to improve quantity and quality of eggs and sperm?
So, okay, let's start with eggs. So eggs, we're born with all of our eggs. So we can't really increase the quantity of our eggs. In fact, throughout life, our quantity goes down. Quality is also, right, like if we're born with all those eggs, no supplement can truly increase the quality of those eggs and make an unhealthy egg then become healthy. The thought about some of the supplements is that maybe they support the growth of those healthy eggs. What I would say is that from a sperm perspective, so eggs, you're born with them, you lose them throughout life. Sperm are always being regenerated. So anything that's happened to you in the last like 10 to 12 weeks is going to affect your sperm health. So this is including things like lifestyle choices, caffeine, alcohol, nicotine, marijuana, other toxins that you're exposed to. There's a bunch of guys who have workplace exposures because of certain jobs people have or hobbies. So any kind of toxins, fumes, anything on your solvents, on skins, those kind of things can certainly affect it. Certain medications that people take for other medical conditions can affect it. Don't stop taking your medication, but sometimes that can be a factor. And then other things like fever. If you get sick and have a high fever, that can affect it. Or if you're going in a hot tub that's 103 every night, it's similar to having a fever, right? So I think that there are some lifestyle things for sperm that you can do to help, but remember, it's like that's almost that 3 month, 2.5 to 3 month period of like needing to make good, healthy choices. It's not like it happens overnight.
I always learn so much when talking with you. Dr. Go, do you want to take this one? What about AMH level? Can you improve your AMH level?
Yeah, so AMH or anti-Mullerian hormone, it's a hormone that's produced kind of like we talked about by all those small resting antral follicles in your ovaries. So kind of like Dr. Rodgers was touching on, we're sort of born with all those eggs that we have in our ovaries. That being said, AMH can fluctuate over time. So, it's a marker, it's kind of a snapshot of the ovarian reserve you have at that time, but it can fluctuate a little bit. And so again, no real way to make it go from like a 0.1 to a 3, but it can fluctuate, and we can support overall egg health by avoiding some of those toxins like smoking, and supplements can support the eggs we do have. But again, hard to make it really change drastically. But if we check it at different points, it can fluctuate. Overall, I will say though, it sort of trends down as we age with our egg quality and quantity.
Thank you. I have one more question about just fertility health and I guess aging. If someone did fertility testing 5 years ago, they're now 40 years old, would things be drastically different? Dr. Rodgers, do you want to take that one?
Sure. So let's say if you're comparing a 35-year-old's fertility to a 40-year-old's fertility, there can be a huge difference. Now, a lot of women at 40 are able to get pregnant, and that's great. But there are a significant number of women that have a pretty big decrease in egg count and quality between age 35 and 40. Around 38, you see a pretty big inflection point where things go south pretty quickly. And most women are losing all of their healthy eggs somewhere between 42, 43, 44. So the older we get, the higher the percentage of eggs that are abnormal. So the fewer eggs we have total, and then the fewer percentage that are able to make a baby. So it's sort of a double whammy there. And this is why it's so good to sort of just get your fertility tested so that you can see where you are and where things stand.
Thank you so much. So I'm seeing in the comments some questions about IVF. My clinic waits 7 days for embryos. I've read they have lower success rates than day 5. Any insights to share?
Well, I can tell you about oh, go ahead. You can.
Oh, no. I was going to say, so so typically most clinics will wait the full 7 days because we like to see if any fertilized eggs become blastocysts on days 5, 6, or 7. So any embryo that reaches the stage of a blastocyst is going to have a higher chance of success than implanting like a morula, which is more of an early stage embryo. That being said, if a blastocyst reaches that stage of a blastocyst on days 5 or 6, that means they're a little bit more on track. So definitely a day 5 embryo is going to have higher rates of pregnancy than a day 6 embryo, and day 6 is going to have a little bit higher than day 7. And that's just because it kind of reached that ideal stage of implantation right on track. But again, if you have a day 7 embryo and that's what you have, and you just have a day 7 blastocyst, letting it get to that stage is better than if you were to freeze it or try to put it in while it was still, a collection of cells that hasn't really formed into that separation.
I love how you explain that. Yes.
I was going to say, Dr. Rodgers, anything to add?
No, I mean, in our lab, there's not a huge difference between day 6s and day 7s. But, I agree with everything that Dr. Go said. I think that they're still worth using. They still make babies all the time. So I wouldn't give up on your day 7s.
Thank you. If someone only had 1 to 2 follicles, would you still do, this is retrieval, but, oh yeah, retrieval, that makes sense. Dr. Rodgers, do you want to take that?
So we have we have a policy at our lab that we like to have at least 3 mature follicles to really make it worth it. When there's less than that, we just don't see a whole lot of success, and we encourage patients to either cancel or convert it to an insemination. So our recommendation is to have a minimum of 3 follicles, because remember, of the follicles you have, they're not all going to give us eggs. They're not all going to be mature. They don't all fertilize. They don't all grow normally, and they're not all going to be genetically normal. So, I do think that most clinics probably have a minimum that they require to move forward with the retrieval. At our clinic, it's 3. Not 3 per ovary, but just 3 total. Certainly exceptions are always made for different situations. But I think that is sort of best practice. And gosh, it's really hard when you have such few eggs. And sometimes it's worth it to maybe ask for a one-time exception so that you can at least get to a retrieval once. If 2 is the most you can do, maybe. But if you're not successful, then it may be time to start thinking about alternative options, such as donor eggs, which is really hard.
Thank you. So you mentioned possibly switching to an IUI. We have some IUI questions. First question was, when should you choose between a medicated cycle and intercourse and an IUI?
Who's that question for?
Oh, sorry, Dr. Go, you can take this one.
Yeah, of course. So if you're doing ovulation induction with either timed intercourse or IUI, I usually like to think of, well, what is your diagnosis, right? Why are you doing this in the first place? So for something like unexplained infertility, a lot of our literature has shown that ovulation induction plus IUI is going to be sort of the baseline treatment or the most conservative treatment you want to do. So in patients with unexplained infertility, we've seen that just doing medications alone with intercourse has not really been that much more effective than just having intercourse alone, right? So why add the medications if the medications doesn't improve your success much more than what you were doing at home already? So definitely for our unexplained infertility patients who are opting for the ovulation induction route, I would 100% recommend they pair their ovulation induction with IUI. In some other cases where maybe the problem is just PCOS or anovulation, sometimes patients who are really getting a huge benefit from just the ovulation induction alone, they might be good candidates to just pair that with timed intercourse, as long as the sperm is really healthy, there's good counts, there's good motility, because they might not have as huge of a jump in terms of efficacy increase by adding that IUI portion. So I would say it depends on what your diagnosis is, and obviously making sure the sperm is healthy and has good enough motility, again, because the sperm has to navigate all the way from the vagina through the cervix, up the uterus, up to the fallopian tubes. Whereas when we do IUI, we're dropping that sperm off a lot closer to its target, right near the fallopian tubes. I don't know, Dr. Rodgers, what do you think?
Yeah, I mean, I couldn't have explained it better. That is, so a little known fact, Dr. Go and I trained at the same facility, a few years apart, but so I feel like we have the same like vibe about like how we counsel on stuff. But yeah, I think that's really good. The other question I get asked is for like maybe single or same-sex women who are doing inseminations, or if you have just like male factor, if you can't, like some people just can't have intercourse. Sometimes natural cycle with inseminations can be good, but again, if there's unexplained, the inseminations on their own aren't better than just trying on your own.
Thank you. And Dr. Go, I don't know if you want to expand on this too. Someone during the webinar had asked what medications you prescribe when you're doing an IUI. Do you want to give a quick overview on that?
Yeah, I love this one too. So for the most part, when we do oral medications with IUI, we either use something called Clomid or something called letrozole. And we can use both interchangeably in certain cases. A lot of times patients with PCOS will elect to use letrozole. There's been some studies that show it has a little higher live birth rate in that population specifically, but Clomid, I will say, has been along for a really long time, and we've used Clomid, for many, many years, and both of them work in a similar way, actually, which is kind of an interesting way, is they actually decrease your estrogen, or it almost tricks your body into thinking you don't have enough estrogen, and so it fires up your brain to send more of that FSH, to get your ovaries to respond more and hopefully grow more follicles. So letrozole and Clomid are the main oral medications we use for ovulation induction. And again, they both kind of work to modulate estrogen and sort of trick your body into growing more than one follicle at once.
Thank you. Dr. Rodgers, we have another IVF question. This is someone who's had multiple PGT tested embryos. None of them were viable. Is there a point where IVF does not work?
Oof, yes. I mean, of course, unfortunately, IVF is not 100% guarantee. So sometimes if it's, I don't know that, obviously I can't speak to this very specific case, but in general, if you're having embryos that are genetically tested and not implanting, we call that sort of recurrent implantation failure. And it takes you down a whole road of workup and testing, which if it's still not successful, sometimes people need gestational carriers. Certainly then on the other side, if you have eggs that are being retrieved, embryos that are growing, and you're sending them for genetic testing and then they're not coming back normal, I'm not sure which scenario we're thinking about in this particular question, but like if you just keep sending embryos and they keep not being normal, that's a scenario where an egg donor may be more helpful for you.
Thank you.
There's always a pathway to a baby.
Yes.
There's always, right? It may not be the type of treatment or the type of path you were initially expecting or wanting to do, but like everybody can leave this journey with a baby.
Yeah. If anyone wants to read some inspirational stories, if you go to fcionline.com in our resources section, we have many, many stories that people share because they were just so excited to like have the family they waited so long for. People who used a donor. We have all kinds of stories, all different scenarios, but lots of donor stories actually on our resources page. But this question either of you can answer because I know it's personal opinion, I guess. Well, not entirely, but thoughts on acupuncture for fertility. How do you feel about acupuncture?
You want to take it or want me to take it? I'm happy to take it.
Yeah, you can. I feel great. So I think acupuncture is something that has minimal risk and it has the potential to help a lot of patients, right? I actually think the data for it is decent as well, right? There's so many kind of fertility supplements out there that haven't really been proven to improve outcomes. And acupuncture is one of them that actually has, like I said, some decent data behind it. So I think the risk is minimal. It has the potential to help. If nothing else, I think it can help alleviate stress and bring a little bit of, peace and calmness to a really stressful journey. And so I support acupuncture. Again, if you have the means and the times to do it, I think it's a great option and a great adjuvant. I wouldn't recommend acupuncture as your sole fertility treatment. I think it needs to be kind of paired with some other things, but I think it's a great avenue to go down and use to supplement your treatments.
Thank you.
Yeah, I agree. I will say like there is some, a lot of the data, and please correct me if you've had more newer data that you've seen, Dr. Go, but like a lot of the data doesn't necessarily move the needle in terms of like a baby to take home. So it's not, unfortunately, going to be like the thing that probably changes a whole lot, but people say, people can experience fertility treatment much easier when you're having sort of an extra stress management tool like acupuncture. And so I'm a huge fan. In fact, when I went through fertility treatment, I did acupuncture and I was like not so excited about the thought of like needles all over, including like my face, but it actually was amazing and really like didn't hurt the way you think maybe it would. I encourage everyone to try it. And if that we have some great acupuncturists we work with, and always happy to if there's people who are local who want advice on who are our patients, we're happy to sort of give you the list of people we work with.
Thank you. This one's about endometriosis. Can you have endometriosis without any pain? Especially if you have like unexplained infertility, do you think that there could be like something that someone's not seeing maybe?
I can take, you take this one. Either way.
I feel like where we trained was so big in endometriosis. So yes, you can definitely have endometriosis without any pain, right? And I think that's what's so hard about it sometimes, and that's why it's called the silent disease, and it's underdiagnosed. And there, a lot of people can have endometriosis without us knowing. Definitely, the higher incidence is among people with pelvic pain, but also we see a higher incidence just among people with infertility in general. So you can have that infertility component, and that can be your only symptom of endometriosis. I will say, that being said, we don't often just jump into laparoscopies or doing surgery on these patients if they, without having like something to remove, or without having significant pain. There's been a lot of research into saying, well, can we do surgery to just improve fertility outcomes in patients with endometriosis? And it's kind of a mixed bag, and it kind of depends on the severity. So I will say, we don't always jump into surgeries in the cases of unexplained infertility if we think there's underlying endometriosis without, like I said, symptoms of pain. And that can be really frustrating, I think, because, right, we have no other great way to diagnose it at this point. We have some, promising studies and trials on the horizon, hopefully, to kind of close the gap in how we diagnose endometriosis. But silent endometriosis is definitely real.
I think the question that we have to ask ourselves as providers is, are we going to do anything different based on the outcome, right? So I think surgery, for example, has risk. And, if we're going to proceed through the same fertility treatments, then we would just kind of continue. There are some less invasive tests, as Dr. Go sort of mentioned. So there's one called BCL6. It's a marker that we can look at, a special marker on a biopsy sample of the uterus that tells you if there's a certain kind of inflammation that is associated with endometriosis. So now this test has to be done during a certain part of your cycle. The test is like $700, so it's not cheap. It takes a few weeks to come back. It requires a biopsy, which you don't need anesthesia. It's not horrible, but it's kind of a 10-second cramp. So there are some things that we can do. The question though is what are we going to do different based on that?
I think that's a great point. Let's see. Dr. Go, if you want to take this, how common are polyps and how often do they return after removal?
Good question.
Yeah, it is a good question. And it was so good that I was thinking about this, because this one was from the webinar, and I was like, what is the literature? So I went back and looked. There's such a wide range, honestly, of what's reported. I saw anywhere from 8% to 40%. But what kept coming up, and what I think I like, is, again, a wide range, but about 30% in a lifetime risk. And that's because as we get older, there's more and more of a chance to have polyps, right? That makes sense. The longer you have a uterus, the more chance there's overgrowth of the tissues. And so the chances increases with age, most common in third, fourth, fifth decades of life, but can be seen earlier. We remove them and we hope they don't come back, but unfortunately, a lot of times they can. And the longer we wait, the more likely they are to come back, right? That kind of makes sense. In about a 2-year recurrence rate, it's about 21%, and a 5-year recurrence rate is as high as 40 to 50%. So a lot of times, that's why if you've had polyps in the past and you haven't had a peek inside your uterus, we'll always want to check and make sure your cavity is clear before we do any sort of fertility treatments or let you try to get pregnant again. Just because once you have them once, kind of like anything in obstetrics and gynecology, it's just likely to happen again, right? We can get polyps anywhere, in our nose, in our uterus, in our colon. And so they can definitely come back. Usually, after we remove them, though, I would say you have probably a good 6 months to a year where I would feel pretty comfortable that they should be at bay. So if you have a hysteroscopy to remove polyps in the beginning of the year, you're probably good for a transfer or trying to get pregnant, definitely for the next couple months, next 6 months, and hopefully up to a year as well.
Thank you. Dr. Rodgers, I think you've had some videos of removing polyps, have you not?
Yes.
On your social media page.
I know some people get kind of grossed out by surgical videos. I think it's so cool, but this is what I do all day. So I find them really interesting and fun. I
And it's so
think that people,
satisfying.
right.
They're so
Oh,
fun.
especially. Oh, yes. I mean, I probably like, I had 4 hysteroscopies today and I probably took out like 50 polyps in those people because some of the people like had all these little polyps all over the place and you have to sort of take them out. So they're really, really common. And yeah, I like to do um updated imaging like every 6 months in treatment if things aren't working, or like after like a failed transfer if it's been a while, those kind of things. Certainly after a miscarriage, want to make sure all the tissue's out, that kind of stuff. But yeah, I mean, uterine pathology, and unfortunately, the reason we take out polyps is number one, it causes issues with infertility, but number two, it can turn into cancer. And like, unfortunately, fortunately, it's very rare. But, I sometimes have to call patients and let them know that, we have to pause fertility treatment to make sure their uterus is healthy to continue. So that's always hard.
Um, so speaking treatments, we have another question about IVF. Are there side effects on the female body, specifically obesity, but are there any other side effects that someone can expect when doing IVF?
Yeah,
Dr. Rodgers, if you want to take that
Yeah.
one.
So, when you're on fertility medications in general, we're asking your ovaries to work harder. So even if it's Clomid or Letrozole, right, we're asking your ovaries to make more than one egg. Now, sometimes we give you a dose and you still make only one egg, which is always frustrating for everyone involved. But in general, we're asking your ovary to work harder. With IVF, we're asking your uterus to make, or your ovaries to make a lot of follicles. And as the follicles grow, the ovary gets kind of stretched. And so some of the symptoms from that, sometimes people can have some cramping, some bloating. And truly, I don't want to say it's a good thing you're having cramping and bloating, but it means your ovaries are responding to treatment. And I try to think about it in a positive way, that is sort of like a good thing to expect because it means that your body's responding. We don't see fertility treatment causing a whole lot of obesity. Obviously, a lot of the fertility treatment we do, you're only on medications. Like for IVF, you're only on medications for about 10 days. And so in a 10-day period, certainly your hormones fluctuate. You can feel more hungry. It's a stressful time. Sometimes we get a little more hungry. Or eat from stress. Sometimes you can gain some water weight, certainly especially like afterwards, but that is all just sort of very temporary. There's really no long-term effects that you should see.
Great, thank you. Dr. Go, if you want to take this on, another IVF question, do you have any thoughts on after a failed cycle, failed medicated cycle, doing a modified natural cycle? Any thoughts on recommend,
About
not
frozen
recommend,
transfers.
need more information?
Okay. Yeah. So just a little bit of education. So there's controlled cycles where we kind of completely take over what your body's doing. We shut down your ovaries and we manage, we're giving you estrogen, we're giving you progesterone. And then whereas a modified natural cycle is we're relying on your body and your ovaries actually to make some of that estrogen and to make some of the progesterone. So we're utilizing kind of what we have. In terms of success rates, they've actually been shown to be pretty comparable in terms of the outcomes. I would say benefits to one or the other is kind of what you're looking for, right? So the controlled cycle might be a good option for people who have really irregular cycles, or, it's hard to predict what their ovaries are going to do, or they have a really specific timeline where they need to do a transfer. Whereas the modified natural cycle, because we're using some of your body's own hormones, you don't have to take necessarily the injections of progesterone, which can be incredibly uncomfortable. You don't have to take as much. Sometimes you don't take any estrogen, right? We're relying on your body's own estrogen. So I think less medications, a little bit less predictable in terms of timeline, because again, we're relying on what your ovaries are doing. And then the other thing I would say on that same topic is if you've tried one, then maybe it's worth trying the other. That's what I like to think too. Like if we're doing something and it's not working, then let's not do the exact same thing again, right? Maybe we try something else. And I think that's really important with treatment, right? Every time patients come to us, we're like hearing their whole story, especially if we are getting them as transfers from other clinics or from another physician. We have the benefits of what their history showed us. And so we don't want to make the same mistake twice, right? We want to try to make some adjustments and really cater our treatment. So yeah, again, barring any reasons why a natural cycle wouldn't be the best choice in that option, I think trying something different is always a really reasonable option. I feel like Dr. Rodgers loves modified natural cycles. So I feel like you're waiting to jump in.
Yeah, so what I will say, first of all, like I feel like our brains are like fused, Dr. Go, because like I say the same thing. So what I will say is when we looked at our internal data, we saw similar, and when you look at national data,
Yeah.
you see similar pregnancy rates in ovulatory women from natural cycles and hormone replacement cycles, and then in anovulatory women. So if you do a PCOS, you can do a stimulated cycle with like letrozole or whatever, and we see similar pregnancy rates. So there are a lot of options. I think some of it, like you said, is really just if they have the same chance of success, some people, you know, based on their schedule or whatever, you know, want to have a preference of one over the other. And I completely agree. We can't expect to continue to do the same thing and expect a different result. So, you know, for IUI cycles or something, you know, sometimes the chances of success are really relatively low, right? 10 to 15% maybe per cycle. And, you know, typically we do like a course of 3 treatment cycles. And if you're responding, we'll usually try that a few times. But embryo transfers are a little different, right? And if you're not responding, or if you didn't get pregnant from an embryo transfer, the question really becomes is, did you not get pregnant because of an issue with the uterus or an issue with the embryo? And then we have to sort of, if it's sort of a uterine issue, and especially if you've had a tested embryo, right, there's only so much we can do at that point, right? And so trying a different preparation for the uterus sometimes is helpful. It's a great question.
Thank you. So as far as going through treatment, is everyone's protocol different when they come to FCI? Dr. Go, do you want to take that one?
Yeah, so everyone, you know, we only have certain IVF medications. Like we only have so many different medications and kind of different protocols we can work with. But I will say that every patient I see, and I think this probably goes for all the docs at FCI and hopefully most REIs, but I think it should always be individualized, right? Based on the patient's age, based on their ovarian reserve testing, based on their goals, right? If a patient comes to me and says, you know, I want 1 baby versus I want 5 babies, sometimes that'll also change our treatment plan and what we're doing. So yeah, I would say each patient has an individualized protocol within the realm of like, we can't invent new medications off the fly, right? Everyone's going to pretty much be on some dose of like the FSH and LH that your brain is sending to your ovaries normally. We kind of modify that and give it to you in injections. But yes, I would say personalized protocols are, you know, part of what we do, right? That's why we trained for so long, is to know how to tweak things for each patient. And again, even through your stimulation, sometimes we'll change your protocol a little bit.
And everyone has a different style, right? And this is, I always say, this is where the art of the science comes in, right? Like everyone understands the scientific facts, but everyone does things just like a little bit differently or would have a little bit of a different approach, which is actually so nice because, you know, sometimes when I have a patient who's gone through a couple treatment cycles that hasn't been successful, we have our like monthly, you know, IVF meetings where we can talk about difficult cases and I can, you know, see if there's anyone else who has maybe a different opinion, different way to do things, different way to approach a problem. But it's, you know, we all do things a little bit different, but like Dr. Go said, there's only one medication on the market that is an LH plus FSH. There is only 2 gonadotropins on the market that is FSH. That's it, right? So it's not like there's a lot to choose from. It's the magic maybe is sort of putting together a cocktail of different ratios or different levels to help you have the best cycle possible. And There's a couple things. First of all, you could take the same protocol 3 months in a row and have very different outcomes. And there are some data showing that, like, maybe it doesn't matter exactly what your protocol is, that maybe your body's going to do about the same, regardless of exactly what protocol is used. So, I always try my best to put together a thoughtful, smart protocol for patients and like try to figure out what works best. But sometimes it's not up to me.
Thank you. Dr. Rodgers, this is from the webinar. I don't know if you can answer this for me. Can you get pregnant with a 10-day luteal phase? And can you explain a little bit about what that means?
Sure. Okay. So the menstrual cycle is broken up into two pieces, right? So you get your period and then you ovulate. Okay. So we call that the follicular phase, where your ovary grows a follicle. And then from the time you ovulate to the time you get your next period, that's what we call your luteal phase. That is the time where implantation would happen and those kind of things. So the luteal phase should be from the time you ovulate to the time you get your period, about 14 days. And if it gets really short, sometimes that can be a cause of infertility. People are not producing enough progesterone, and the time between the time that they ovulate and the time that they get their period is too short. So we can treat that with some extra progesterone, and we usually give this progesterone either injections or vaginally. And sometimes people, for a variety of reasons, are not producing a strong enough ovulation, not having a strong enough luteal phase. So they're, instead of 14 days, the question is, if it's 10 days, could you get pregnant? And the answer is yes, you can. Now, sometimes having lower progesterone levels or not enough progesterone around and that the corpus luteum sort of, stops producing hormones too early, can lead to what we call a shifted window of implantation. So normally there is a relatively short amount of time, maybe 24 hours, where maybe shorter for people who have infertility, where an embryo can attach and stick. And sometimes that window gets shifted without the right amount of progesterone. That's why if you take progesterone from a doctor that, maybe is just saying, hey, take some progesterone, sometimes, naturopaths or maybe just general doctors would give someone progesterone. If you're not taking it exactly the right time, it can actually decrease your chance of getting pregnant because it shifts the window of implantation. And so typically we will give you medication for that. I do think those people are at higher risk for things like biochemical pregnancies, maybe miscarriages. But yes, some people get pregnant with a short luteal phase. I think those are people who would benefit from help to increase their chance. So,
Right.
Absolutely.
Thank you. Thank you. I just learned so much there too. So I think this is a good question to end on, because I don't see any more questions that we haven't answered within the chat, unless you noticed something. Oh, wait, here is one I missed. If you are young and you have your egg count is low, but you're young, should you do IUI or fertility treatments?
Oof, or like IVF?
Yeah.
Good question.
I think maybe one, how low? Two, what are your goals, right? If you just want, one baby, then maybe it's worth, you can try a little bit more conservatively. But again, like we touched on, the concern is that whatever your egg count is today, it's just going to keep decreasing with time. And so I think it's important to think about what's your family size goal. And I don't know, go from there. I don't think there's one clear answer that you have to do one or the other. I think IVF is going to be your highest chance of pregnancy, but it doesn't mean that's your only path to pregnancy, especially I think when you're young and maybe if you haven't been trying that long, and you just did your egg testing. I don't know. How do you counsel those patients, Dr. Rodgers?
I mean, I agree with you. I think the one thing that some of those patients may want to consider is fertility preservation, freezing eggs or embryos. If they want 3 kids and they don't have any, and their egg count's crazy low, like maybe it's worth like trying to get some eggs to freeze, or embryos for the future. But it can be really hard, and sometimes it's not super successful if your egg count's super, super low, and just But I think that sometimes, as the egg count drops lower and lower, sometimes the chances of success with less invasive treatment becomes very similar.
Thank you. And one more, can you get pregnant after menopause?
Well, with help, yeah. I mean, there are some people who go through menopause at like 20. I mean, that's not normal, but like, yeah, we can help those patients who have early menopause or even menopause on time. So, you don't always have eggs, right? When you go through menopause, you don't usually have any healthy eggs, but yeah, this is the magic of what we can do.
Great, thank you. We did get a couple new questions. Is it abnormal to have a period and then start spotting after a week?
So is it abnormal? So yes, I would say probably the bottom line is that's abnormal, right? That concern for that is it intermenstrual spotting, right? Could that be a sign of something like a polyp or, something else in your uterus that shouldn't be there? Or the other question is, are these actually irregular cycles, and is it more anovulatory bleeding? Like, when we think of a true period, right? A true period is you shedding your lining after you've ovulated and did not gotten pregnant. But some patients who don't ovulate regularly, so like patients with PCOS or they have thyroid issues, so they're not ovulating regularly, they'll just kind of spot here and there because their lining, like they don't have the hormone fluctuations to just shed their lining completely. So they'll kind of have some bleeding here and they'll have some bleeding there. And so
I call it unstable.
yes,
They have an unstable
yes,
lining.
exactly.
Yeah.
So I would say no. I mean, the short answer would be, it's not normal to have like bleeding for a week, take a pause, and then another bleeding for a week. So, sometimes cycles are weird, and if that only happens once, or it's happened like a couple times in your life, probably not a huge deal. But if that's happening pretty regularly, definitely a reason to, get checked out, go see your OBGYN, come see us. I think of periods as right, it's like a marker of your health, right? So your cycles are really reflective of a lot of things. And so it's important to kind of keep a close eye on them. And if you have any concerns, get checked out.
Yeah. Yep.
Anything you want to add, Dr. Rodgers? No? Okay.
No, we think about them as a vital sign. So yeah, I mean, and it's important to advocate for yourself, right? Like if something doesn't feel right, doesn't seem right, go get it checked out.
And speaking of getting it checked out, if you are going to consult with a fertility specialist, what can you expect at your first consultation?
You want me
to answer
this? I can answer
this. I was like, take that one, Doctor.
Yeah, sure. Okay. So, I mean, I usually talk to the patient, either individual or couple, and go through their medical history, their previous fertility journey, if there is any. I like to go through goals. How many kids do they want? Those kind of things. And then I go through the testing that I would recommend for them. So based on what they're telling me, I go through like a list of tests that I want to do. I end up putting together a digital checklist of sorts to make sure that all of the things we talked about get done. Review any records I need to. We order the tests, they get them done, and then they come back to talk about where we go from there. What kind of treatment would be helpful for them. So usually, I mean, everybody does things different. Every clinic kind of does things different. Typically, it's just a conversation. So we're not asking anyone to on the spot give us a sperm sample or like go get a internal ultrasound right away. Like we just talk usually, and really I try to learn everyone's history, where they've been, where they want to go, so we can kind of start putting the pieces together.
Perfect. Thank you. And Dr. Go, do you want to answer the second part of this question? Should both partners, if you're in a relationship going to a fertility doctor, should both partners go to the first consultation, or can it just be one?
So, I mean, I would say yes. I love if there are two partners in a relationship. I love when both of them are there. I usually get history from both partners when it's applicable, and it just kind of helps for two people to hear. Sometimes it can be a lot of information to process, so kind of having someone else there to ask maybe questions that one the other one forgot to ask, or when they get home, they can be like, oh, what did they say again? So I think always really helpful. But the other piece is, if your partner can't make it, it's okay too, right? We can take notes. We'll have a follow-up visit. So I would say yes, if they can make it, always bring a partner along. But if schedules don't allow it, right, it's not the end of the world. And the other thing we can do too, for some telehealth visits, I think is so cool. We can basically chime in. We can all tune into the same video
Like
call.
this.
Like this. Yes, exactly. So, if one of you is at work and the other one of you is at home, or you're both at work, or one of you is doing errands, whatever, we can talk to both of you at once through telemedicine. So we're flexible in terms of what we do and who we kind of see at visits.
Thank you. Dr. Rodgers, I see a shout out for you. We have someone with a 15-month-old. Thanks for the help of Dr.
Oh my God, I love that so much. It's the best.
All right, looks like we have one more question. Can you implant and still have an issue with your lining if it's a normal embryo that's been PGT tested?
I mean, yes and no, right? Like, yes. So could you have a scenario where you have, theoretically, if your lining is healthy, then and it allows implantation, it should be fine. Although you could see a scenario where maybe like the window of implantation was shifted, the lining wasn't maybe super great, and that maybe could lead to something like a biochemical pregnancy. But usually like miscarriages that you see at like 6 to 8 weeks, which is the average, typical time where you see miscarriages, are more related to fetal issues. And usually if you've had implantation, that's a good sign. I don't know if you have anything else to add to that, Dr. Go. That's a good question. It's really a challenging one.
Yeah, it's always a question, right? Is it the embryo, or is it the uterus? I would say in the majority of situations, it's probably a little bit more the embryo, but yeah, I mean, it can always be the uterus too, right? There's so many factors. We can't control everything perfectly. But that's why, we try to address things from both ends.
Yes.
Thank you. It looks like that's all the questions we have, although we do have some more shout outs for Dr.
I know, so
Baby.
many babies.
I know. You know what I haven't done yet, which I really need to do, is go through my 2024 pregnancies. Like, now that we've gotten a little further, like my very last transfers of the year, like how many of those people got to graduation. It is a little bit fewer than last year. So like last year I had like one a day, and I have to do some counting. I think I'm at like 335 or 340. So like still really good, approximately one a day. So that's a pretty awesome
leave
thing.
room for like weekends and holidays.
I guess, yeah. Fine.
Thank you so much. Is there anything else you want to share? I'll share how to make an appointment. Visit fcionline.com, request an appointment, or call 877-324-4483. If you're not one of our patients already. Dr. Rodgers, Dr. Go, anything else you want to add while we're on?
Advocate for yourself. Don't give up, and come and see us if you need help. We're here.
Yeah, exactly. It's never too early in your journey to come see us. It's never too late in your journey to come see us. So we want to meet you and help you, and if nothing else, at least, provide you some education in terms of your fertility in your body.
And if you're interested in any more resources like this, we do have a frozen embryo transfer webinar coming up on February 26th with Dr. Arlene Go. We do go over controlled, medicated, oh my gosh, now I'm forgetting it, but I'm not the reproductive endocrinologist.
Stimulated, yep. All the cycles.
Yes. So that is one of the topics we will cover. But yeah, thank you everyone for joining us. Thank you, Dr. Rodgers, for inviting us to do this.
Yeah.
Oh yeah, I'm so great. So fantastic. All right, have a great night, guys. Thanks for joining.
Monday. Take care. Thanks everyone. Bye.